afternoon, everybody. We've got about a minute and a half to go, and you have an Australian and a French kind of moderators, and we've decided we're going to be nice to each other despite the fact that the Australians aren't going to buy any more French submarines. So that's really good. Chris looking at me, what does that mean? He doesn't know international news because the Americans are now selling us the submarines. So in any case, Bruno Francois and myself are going to chair what I think Bruno was telling me is the best session at this time of day because it's about future therapies of sepsis. So without further ado, Chris Seymour will be telling us about focus on disease tolerance in sepsis. Chris, the floor is all yours.
Okay, good afternoon. Thank you. Yes, Chris Seymour, University of Pittsburgh. It's nice to see you all here. Gentlemen, thank you for the introduction. I will not make any political or military comments, although I do like the F-35. It's a very cool jet that flies around. Okay, so the title of this session is Focus on Disease Tolerance. It's going to be very short because there are a lot of really cool talks that are about to come that will relate to clinical practice, maybe in this moment, but then particularly in the future. But I'm starting a little bit with a conceptual beginning. And we're going to talk a little bit about conceptual models and how they might inform our investigations and use of these future therapies. So those were my conflicts. Again, this is the brief agenda. We're talking a little bit about sort of this notion of disease tolerance and organism tolerance as a in some respects for our field, a new bit of our conceptual framework for acute illness and particularly sepsis. And then show a little bit of new data about how these domains may inform the mechanisms of heterogeneity, which we heard in detail a lot about this morning from Tony and Carolyn. Okay, some caveats. There are some in this room that spend all their days thinking about conceptual models, thinking about how we build clinical trials, and all types of translational science. My expertise is somewhat a little bit of everything, probably expert in none. That was unusual. And although conceptual models often get shown, right, it's the first slide of a talk, or it's the first paragraph of a grant, I'm sort of posing the question whether our field is really studying them enough. And too many challenges to solve. So if we think in this example, sepsis is the entity that I focus on. It's the topic for the day. You could also think about other inflammatory conditions, whether it's pancreatitis, trauma, et cetera. There's a lot going on, right? This isn't just QSOFA. There are a variety of biologic mechanisms underneath the surface that are normal, that help us regulate our response to infection, but then also, to use the word from the definition, there's a dysregulated bit of this response. And when we think about how a conceptual framework might sit on top of that, it becomes like really hard. And so this is sort of some of the principles that go into these conceptual framework. You guys can read the words on the slide. It's too many to go through, but they help us sort of frame potentially our future observational studies. Maybe they help frame what mechanistic pathways we can look for candidate therapies. All right, so it's useful to think about some examples. And so I turned back the clock to sort of the vintage of Ronaldo and Bruno and have sort of some of these models that I hope look familiar to everyone in the room. So this is from one of the earlier sort of proposals about SIRS and systemic inflammatory response. And we can see some overlapping circles, which might help us sort of understand that, you know, some patients may look the same, but because of very different etiology. But you'll notice, if you were an epidemiologist, you would think that where are the arrows, right? Where are sort of the connections that might have cause and effect? And those aren't present in this I would say, older framework. We have then another framework that was proposed around, I guess it was around the time of Sepsis 2. This is the PIRO concept. We talked a lot about this in our roundtable with John Marshall and the many others that contribute to this, that has elements that help us think about a predisposition to sepsis, the pathogen itself, how the body responds, and then the different organ failures that may result from our host response. Now, this has a lot of face validity, and I think we could probably sit in a room and talk about how to study it, but it doesn't necessarily incorporate probably the depth and breadth of biology that we might want to use to inform candidates. Okay, so then we get into something like this, and the graphics look better because these are newer pictures, but this is one that's maybe showing sort of a little bit more mechanistic influences. We've learned about PAMPs and DAMPs, and I'm not going to go through every bubble on every one of these frameworks, because I do think many of you know them, is that it's sort of perhaps informing a bit more, but I would say that this big arrow that we often see going from sepsis to severe sepsis or shock is a little bit misleading, right? There is no sort of linear path by which our patients travel through this illness, and certainly there's no linear path out of it. Okay, so then we get to sort of graphics like these, and again, this is, you could sort of envision Richard Hotchkiss standing here, or Tom Vanderpool, or many of you as well in this room, who've thought about this balance between the innate, the adaptive immune response, secondary infections, and sort of these models have both clinical relevance. They're starting to include bits of biology, but they are not, I will say, although there are lots of cytokines up here, they aren't very specific in terms of pathways of interest. Okay, we might be getting tired of seeing examples, but here's another one from Manu Shankari, Mervin, and others that was recently published that's starting to introduce new domains, not just host inflammation, but rather other elements that are involved in sort of our evolutionary conserved response to infection. And this is where we start to think about concepts advanced by our immunology colleagues. So there's a very well-known conceptual model that we'll talk about from Medzitov, Suarez, Sebastian Weiss, Michael Bauer, many of these scientists who are thinking about how we respond to pathogens using things like avoidance, or perhaps a very subtle but important difference between our resistance to an infection versus our tolerance to that infection. And you can see these words are now starting to show up in these conceptual models, and perhaps with even sort of therapeutic implications. So there's a variety of different sort of downstream thoughts you might have, depending on what you're building your conceptual model for. But what I might propose here is one that I think sort of encompasses a bit more of our current understanding. And again, I won't go through every arrow or circle, but this comes from particularly the graph on the right for you is from Janelle Ayers in California, who's really showing this relationship between host well-being on the y-axis and pathogen load on the x-axis. And it wouldn't be surprising to us that our host well-being would decrease as our pathogen load increases. But how do we move back up the arrows? We move back up the arrows with resistance, which is our way of fighting infection by reducing pathogen load. But the slope of the line becomes less, and we move back up closer to health through tolerance. And so at this point, you might ask yourself, well, what is tolerance? And well, that is it in simple words. It's the host's ability to respond to infection independent of the pathogen load, and is often seen by our sort of regulation of our immune response and reduction in immunopathy, meaning eliminating the harms, the sort of collateral damage that our body causes in its initial immune activation. Okay, but there are issues with tolerance being introduced into our conceptual models. The first is, as you might have just heard me say, the key aspect of this domain is that it's independent of the pathogen. And so for those of you who do preclinical work, you might be like, okay, I can sort of manipulate the pathogen load in my experiments. But in humans, this is, of course, not the case in most translational science, nor do we really have a way to measure this. Right? We don't have a way to measure pathogen load in real time, nor would all of us probably agree if we sat down and said, well, what are the biomarkers or the readouts of tolerance? There's some experimental work in metabolic pathways, but there is no sort of set of biomarkers in the blood where we might be like, oh, yeah, that's That one's tolerance. So we didn't know, so we asked a number of folks at the ISF. So there's some really smart people in the International Sepsis Forum. We did a bit of a modified Delphi and said, amongst this whole library of biomarkers, which ones might you think would align with host resistance, host tolerance, or damage? We had nowhere else to start, so let's go with them. And so Rachel Powell, who's one of my fellows, has been thinking about this and was able to, it was a bit of arm wringing, but was able to have these members in a modified Delphi put down their quarter on which biomarkers went to which category. And then we thought, well, maybe we can use those in a principal components analysis to collapse into single sort of themes and see how those themes map to some of this heterogeneity that's been described in sepsis. So it's taking the conceptual model and putting it on some of these phenotypes, which you saw from our Seneca study years ago. So up in the top corner, if you can read, I know it's a bit small, and I totally get that many of you will not agree with this. These biomarkers have been placed into these categories through expert consensus, things like hemoxygenase 1, Ang1, TIMP, IGF, into sort of this tolerance theme, whereas others were very clearly a damage response. And so these Kaplan-Meier curves here are just showing in the center, sort of reproducibility of the Seneca outcomes, those phenotypes, alpha, beta, gamma, delta. And then on the right, we start to see the prognostic capability of different tertiles of resistance, tolerance, or damage. And I've shown those quickly because I would propose I don't really care much about prognosis in this mechanistic framework. Rather, we're thinking about which pathways align within which domains and what might be able to inform our efforts to find treatment. And so that's perhaps shown in these graphs. So take that chord plot from years ago where we mapped those phenotypes to different organ systems. Here we've taken the phenotypes on the bottom of the chord plot and showed their relative importance according to disturbances in tolerance, resistance, and damage. If you want to look at the pie charts then, you can see that for the alpha phenotype, which tended to be less ill with lower organ dysfunction, has this great big red coloring corresponding to a predominant damage theme in the biomarker aberrations. But that's because they were normal, right? And in contrast, in the delta phenotype on the bottom right, again, we see this very large damage signal, but it's in the opposite direction. And that's shown here in these bar charts where we see particularly of interest is in the tolerance biomarkers. They had a higher contribution in alpha and to their better outcome and a very low damage signature. Whereas we see that's quite different in the delta phenotype, where the damage signature is quite high and tolerance is low. Okay, so this is all hypothesis generating and early, but I put this at the beginning, well, thank you for putting this at the beginning of the session because it allows us to think conceptually about many of the therapies that are going forward. So I propose that sepsis conceptual models need continued reassessment and incorporation into our sort of therapeutic sort of pipelines. Tolerance, disease tolerance, which is different from immune tolerance or our ability to not react to autoantigens, is well known to immunologists and I think is gaining increased traction in acute illness. Sébastien Weiss, who's here in the audience, will be talking about this again Thursday afternoon. There's even clinical trials now that are testing interventions focused on augmenting tolerance. I do think future therapy should consider this domain, but there are a lot of questions we've identified. What is the signature? How do we measure pathogen load? Is this organ specific? And is this all just about metabolic reprogramming? So thank you for your attention and interest. I'm going to wrap here, and that's it.
Thank you very much, Chris. Are there any questions from the audience? While we wait, I might ask you one. Chris, one way to operationalize the pathogen load might be to use blood cultures and look at time to first identification of growth. So, some blood cultures will grow in 1 hour and some others will grow in 12 and some others in 24 hours. You probably can get that in Pittsburgh from microbiology, and it would be interesting then to see if there is a relationship between that and specific outcomes and specific patterns. And the question is, would you be game to set up a registry where you actually identify all these bloods that the microbiologists have and get some stuff on the biomarkers.
Yeah, I think that's an interesting idea. Thank you. Right. We often see when the cultures come back in 4 hours, wow, man, that patient's either really sick or has a large pathogen burden. I think could be a really nice surrogate. Thank you.
Any questions at all? Thank you very much.
Thanks.
We'll move to the next speaker.
Okay, so it's my great pleasure to introduce Tobias Welte. You all know about Tobias Welte from Germany. He has a pretty extensive experience with pulmonary infection, and he will talk about immunoglobulin. The floor is yours, Tobias.
Yeah, thanks for the kind introduction. Well, this is about drugs in development, and I'm in the field now for 39 years, and I know immunoglobulins for 39 years. So it's not very new, but what I can tell you, and I will show you the data, the horse is still running. So there are new trials coming up, and I want to give you an overview. So first, immunoglobulins in sepsis. There had been a huge number of studies, bigger ones, smaller ones, some in trend positive, but all together, all meta-analysis. Finally, and I show you one of the Cochrane meta-analysis here, had been negative. To be honest, there are several reasons why this takes place, and one, and this had been part in the recent talk, is that septic patients still are very heterogenic. And this heterogeneity is a big problem in sepsis trials, and not a lot of trials, or to be honest, not one trial, had been positive during the last 50 years. So I'm not so surprised that we had this unfavorable outcome. However, I want to convince you that there is room for being optimistic. One is immunoglobulins had been developed. And what we had done in sepsis for a long time was to use IgG-based immunoglobulins. However, with the approval and the introduction of the IgM-enriched immunoglobulins, and the first one available on the market is trimodulin, we had a possibility to use the advantages of the IgM formulation. And I want not to go into the details, there are 3 major modes of actions together with IgM. It's opsonizing causal pathogens, it's neutralizing microbial pathogenicity factors, not only from bacteria but also from viruses, and it's targeting the host inflammatory response, and altogether it's an immunomodulating agent. There is a clinical development program for IgM-enriched immunoglobulins, mainly for the trimodulin, and I will show you the studies which had been finished, mainly the study in severe community-acquired pneumonia, the SIGMA trial, I was the lead investigator for, and I want to show you where trimodulin is going now. Well, community-acquired pneumonia has an advantage over sepsis. It's much more homogeneous. It's not one, but a small number of pathogens which are responsible. If you are on the intensive care unit with severe community-acquired pneumonia, you normally die due to pneumonia and not to anything else. And the mortality is still remarkable. It's between 30 and 40%. even we have effective antibiotics. I only want to point out, because this is very often not clear, the main pathogen is Streptococcus pneumoniae. There's no pneumococcal resistance which is clinically relevant. All resistance is low-level resistance and is overrun by an adequate dosage of penicillin derivative. However, even with this, 30% of the patients die. And this is due to the quick septic response and the pathogenicity factors, mainly pneumolysin, which is released by strep pneumonia. This was the reason why we started the Sigma trial 10 years ago in severe CAP, a randomized placebo-controlled trial. We had a very long debate with the FDA in the US, and for the first time in this trial, we've chosen ventilator-free days as an endpoint. To be honest, my personal feeling today is that was wrong. And we had mortality only as a secondary endpoint. I think what we did right is we focused on the most severely ill patients, those who need mechanical ventilation. If you look to severe community-acquired pneumonia, 70% of the patients suffer from acute respiratory failure and die due to hypoxemia, and another 50% suffer from sepsis and septic shock and die due to sepsis. And there is an overlap. If you focus on the group of those who need mechanical ventilation, you have a special population who is really severe and severely ill. This is a study protocol, placebo-controlled. Placebo was albumin, and the trimodulin was administered for 5 consecutive days. 161 patients were enrolled, and finally, we missed the primary endpoint, the ventilator-free days, even there was a clear trend in favor of trimodulin. However, if you look to mortality, there was a trend in reduction of mortality for all-cause mortality, but more for pneumonia-related mortality. And then we started a post-hoc analysis, and what you can see here is if IgM had been low at randomization, and this was a very surprising finding because we didn't expect it, that in 70% of all patients there had been low IgM levels at start of invasive mechanical ventilation. And the reason, it's not quite clear, but the reason may be that IgM is consumed in the disease process and cannot be recreated, rebuilt during the severe course of the disease. So altogether, we saw a reduction in mortality in special patient groups, high CRP, low IgM, and the company was able to convince FDA and EMA to allow to move forward for phase 3 study. And these phase 3 studies ESCAPE, same protocol as I showed before, with one important exception. CRP had been included into the inclusion criteria, so you need a CRP more than 70 milligrams per liter to be included, and ESCAPE will start in between the next days in a huge number of countries worldwide. The second indication I want to talk to you, and it is as ever, is SARS-CoV-2. And whenever I talk about SARS-CoV-2, I will be told, well, it's gone. No, it's only gone in our heads. It's still there. So we do not want to talk about it, but nevertheless, for special risk groups, and I put them on this slide, I see patients who are severely ill, and I see patients who die. Most important in the transplantation group, and here kidney transplantation is most at risk, and then lung transplantation. But still in the transplant patients who suffer from SARS-CoV-2 and are hospital admitted, mortality is about 10%, even with Omicron. So Omicron will stay. It will be the new influenza. The disadvantage is influenza will not pass by, so we will have both flu and SARS-CoV-2. We still will see severe cases, and we do with all the development in antivirals and monoclonal antibodies, we do not have enough drugs to overcome the disease. I will not go in detail, but when patients are severely ill and are admitted to the ICU, the host inflammatory response is the main factor of disease progress. And immunomodulating agents are used in clinical practice. Antivirals and monoclonal antibodies do only work in the beginning of the disease, but not when the patients enter the intensive care unit. And from the anti-inflammatory drugs, and I only show you two of them, dexamethasone and Janus kinase inhibitors, baricitinib, there's a reduction in mortality of about 3 to 5%. But this is not groundbreaking, and still patients die. And this is the same with both. So we started a trial using trimodulin in severe COVID, and the first data are before Omicron. They are out of the alpha and delta time. And this is a study protocol, and I will not go through this in detail. I want to show you the results, and it's a little bit the same as we have shown in Sigma. There is a trend in better survival. It's more in subgroups, and you see what we find out in post hoc analysis. If there is a remarkable but not too intensive inflammation, so the very high CRP levels does not react, if D-dimers are still low, and if there's no signal of thrombocytopenia, trimodulin has worked, and therefore the TRI-COVID study had started a month ago in several countries. Some patients are included. However, in the Omicron situation, the inclusion is very slow and it's very difficult to get patients. So I want to go forward with this study, but I'm more in favor to support ESCAPE. So I'm always an optimist, which is unusual because I'm a German. And Germans are half empty glass country guys. Totally different from US and UK. They are half full glass country guys. I think the Australians also. And nevertheless, I think better times will come. We will find new treatments, and immunoglobulins could be a part of this. Thank you very much for your attention.
Thanks a lot, Tobias. We have time for one or two questions. Don't be shy.
Can I ask a...
Oh, yes, of course, Rinaldo. Oh,
Okay,
maybe we
please,
can
please,
leave the floor.
So thank you very much for your presentation. My question, Paulo Mergulhão from Portugal, is regarding the ESCAPE trial. If patients who do better with IgM-enriched formulations have low IgM levels, why not include it as an inclusion criteria in the trial?
Yeah. We had a big debate about this. But if you run a randomized control phase 3 trial all over the world, you have to be sure that IgM measurement is possible in time everywhere. And this is not the case. It's not a post hoc measurement, a point of care measurement in most of the centers worldwide. It does not work in Asian centers or in South American centers. And though we came back to CRP, I would be in favor of measuring IgM, but you can also only use it for post hoc.
Any other question?
I'll ask a question.
Rinaldo?
Okay.
Yeah, please.
So with the trimodulin, do you have any experimental data about the ability of the antibodies, particularly IgMs, to bind to pulmonary pathogens that normally cause pneumonia, so that there is biological credibility to the clinical data?
Yeah, there is a lot of animal models which have looked to this. For example, Streptococcus pneumonia is opsonized by trimodulin, and this is very important for pneumococcal sepsis. Pneumolysine is inhibited. And this is true also for other pathogenicity factors of viruses, but also bacteria. So my personal view at the moment on severe pneumonia is there's no bacterial pneumonia without a viral trigger. Every time you first have the virus, and the virus induces epithelial damage to make the bacterium invasive. And when this is the case, you may need some supportive treatment which attacks viruses and bacteria, and antibiotics in the more severely ill are not enough.
Okay, thank you.
Thanks a lot. Any other questions? So thanks a lot, Tobias.
Thank you.
Well, the next speaker is Tony Gordon, who's going to tell us about immune stimulation instead. Thank you very much, Tony. Please.
Thank you, Ronaldo. Yeah, so I'm going to talk about immune stimulation. I will touch on the drugs, but I'm also going to talk about why we might want to do it and how we might go about paying more attention to immune stimulation in sepsis. My disclosures are shown here. None, I think, relate to what I'm going to talk about today. And just, although I'm funded by the NIHR, the views expressed are my own, not the Department of Health's. So, building on Chris's talk in the first session, the whole idea around immune stimulation sort of comes from our understanding of what sepsis is, and the fact that with Sepsis 3 definition, we moved away from the inflammatory response as being the sole driver, and said that sepsis is this dysregulated host response to infection. As the last speaker said, he'd been working at 39 years. I haven't been around that long, 23 years since I started my research career. And it was very much focused around inflammation. That was the criteria I used, SIRS. But we were aware there was an anti-inflammatory response. I think everybody knew that, thought maybe it came later in the disease process, and it was in these patients with an anti-inflammatory response that may be more susceptible to nosocomial infection, viral reactivation. Of course, we know it's far more complicated than that. Patients move between these different states over time, and in fact, they probably overlap an awful lot. And we get this idea that the immune response is more complicated than simple inflammatory versus then an anti-inflammatory. There's the innate and the immune system. But there's undoubtedly some deaths due to overwhelming inflammation. And there are other deaths, particularly as we treat older patients with more complex disease processes, where there may be later deaths and particularly persistent immune suppression and recurrent infections. So can we do something about that part of our sepsis treatment? Well, this whole idea sort of again is supported through the approaches we took within the GAINS and Genocept consortiums, trying to understand the genetics around sepsis and particularly here looking at RNA profile transcriptomics. So in this work led by Emma Davenport and Julian Knight, colleagues of mine in Oxford and Cambridge, they took the patients with community-acquired pneumonia and looked at the gene expression profiles in these patients and found that they were just looking at the data, two natural groupings, so what we call unsupervised cluster analysis. That we divided these groups up, for want of a better name, we just said their sepsis response signatures 1 and 2. And when looking at what was different about the genes expressed between these two groups, what was quite striking was it wasn't all around inflammation, but many of the pathways differentially expressed were around the immune system, and particularly the SRS1 group. Look, with the genes, the way they were activated, very like an immune-suppressed phenotype, so downregulation of T-cell activation and phagocyte movements and so on. And importantly, these two groups seem to have different outcomes. It was the SRS1, the group that looked like they're immune suppressed, that seemed to have these significantly worse outcomes over time. And this was seen in other independent cohorts. And then with Katie Burnham, another PhD student at the time, now again in Cambridge, we looked at the fecal peritonitis patients, and you could see it wasn't restricted only to community-acquired pneumonia. Here, the fecal peritonitis patients, this SRS1 group, looking immune-suppressed, have the worst outcomes. And when you compare the differential gene expressions, you see there's an awful lot in common between the two. There are some that are specific, I think, that do relate to the individual infection. But the body's response to this severe infection, there's a big overlap. And importantly, if you look at the 3,500 genes that are actually in common between these two types of sepsis, actually there are more genes that are actually down-regulated. This whole idea of suppression in sepsis is not all about activation. There is an element of suppression, which fits with that paradigm that we're talking about, or the frameworks that I think Chris Seymour used to describe sepsis. And I think that we're seeing more and more people are moving potentially away from monocyte HLA-DR, which is shown in this study, which we've used over the years as a marker of that immune suppression that we see. So when the HLA-DR expression on monocytes is reduced, these patients are more at risk of hospital-acquired infections. This whole idea of using gene transcripts, again, we can see looking at these particular ones in this group from Lyon and working with bioMérieux, who have published last year, suggesting again this gene expression profiles can identify this at-risk group. So how are we going to treat it? Well, this is from Richard Hotchkiss, who's been mentioned already in this session about possible treatments. Or we could tackle the monocytes, macrophages, neutrophil, the innate immune system with interferon gamma, GM-CSF, which I'll come back to. There are checkpoint inhibitors, PD-1, PD-L1 specific antibodies. I'm not going to talk any more about that because that's a session later on this afternoon. And then as we move more towards the adaptive immune system and looking at T cells, and the thought of IL-7, which is used in other indications, again being proposed in sepsis as a way to treat the immune downregulation, having potentially beneficial effects, maybe even increasing interferon, but certainly proliferation of the T cells. And why are we interested in lymphocytes? Well, again, we're seeing now that the lymphocyte count may be telling us important information. I certainly know over the years, when I got my differential count, I used to ignore most of it other than the neutrophils, but now I've learned to look at the lymphocyte count. And here you see that it's this persistent lymphopenia up here in the top right-hand corner, particularly where it's persistent, maintaining over days. It's associated with the non-survival. So the ones you see in the light boxes there and the non-survivors, you can see they're tending to have this persistent lymphopenia. And the differences between the overall white cell count or with the neutrophils and monocytes is not quite so clear. And this association seems to hold for mortality in the short term, which is the top Kaplan-Meier curve, over 28 days. But it's even persistent over a whole year of follow-up. These patients have this increased mortality. So tackling the lymphopenia seems important. And in a small proof of concept study, I think, showing that you could give IL-7 to patients with sepsis who are already showing signs of this lymphopenia, you can see in this small study where they were given the IL-7, you can see a more rapid restoration of the lymphocyte count with treatment. So just proof of concept that you're getting biological engagement and activity and early assessment of safety. And I know there are further trials sort of planned in this area to try and understand this, obviously in larger RCTs. Going back to one of the first drugs I mentioned, GM-CSF. This has been suggested in a number of small trials. I'm just going to show you one from colleagues in the UK, led by John Simpson, which again was a small phase 2A trial, which was only 38 patients. It didn't hit its primary outcome, which was to look at the improved neutrophil phagocytosis at day 2. Although when you took the whole time period, there did seem to be an improvement. But you certainly get this idea of where the HLA-DR on the monocytes certainly being upregulated with treatment. But interestingly, it also falls precipitously when the drug is stopped. And so suggesting, having spoken to John a lot about this, maybe we need to treat patients for longer. There are several trials that have gone on with GM-CSF, and when we were interested in this a few years ago when we were writing a grant, we did a quick meta-analysis of these small trials, maybe 300 patients overall put together, and looking at mortality, there was a tantalizing result, risk ratio here of 0.74, clearly confidence intervals crossing 1, but it looked like an interesting signal that needed further testing. And that's what we are planning to do. We got held up because of COVID. We weren't able to start this grant, and in the days before platform trials were all the rage, we proposed what was essentially a small platform trial where we had 3 interventions. I put the other 2 for completeness. We got one around intervention around PCR-based microbiological testing and procalcitonin to guide antibiotics, a fluid strategy, conservative fluids with removal of fluids, de-resuscitation after the acute episode. And then the bit I'm talking about today is the GM-CSF. So comparing it to placebo to see if it will improve outcomes in the high-risk group of patients with sepsis. So this is sort of describes the overall trial. The all-comers with sepsis go into the factorial part, the fluids and the diagnostic. But it's this embedded parallel group trial here, which is the sicker patients. We will get randomized to GM-CSF or placebo, a double-blind trial. So the inclusion criteria are essentially you're an adult in ICU, expected to stay there for 2 days, or as the Australians say, the day after tomorrow, in case they can't count, maybe. Sorry, I apologize. Already receiving antibiotics and already had their fluid resuscitation. And then to identify the GM-CSF eligible patients, we are both prognostically enriching and hopefully predictive enriching. So you have to be sicker, intubated and ventilated, again for another 24 hours, or you have 2 organ supports, so prognostic enrichment. And then also for the predictive enrichment, this persistent lymphopenia for less than 1.2 for 2 consecutive days. We felt waiting 4 days would be too late. And the exclusion criteria for the GM-CSF are shown here. Essentially, you have to be included within the first 5 days. We're giving a higher dose of GM-CSF, which is slightly weight-based, but basically 500 micrograms, and trying to give it for a whole 8 days. It'll be a challenge if the patients are recovered and giving it on the ward, but we will try our best to do that, as I said, to try and prevent the rebound. And as I said, it is double-blind. Our overall sample size is 3,800 for the factorial trial, looking for absolute risk reduction of 5%. We think the enriched group will be about 1/3 of that, and with the higher mortality, looking for an absolute risk reduction of 9%. 60 centres, we think we can recruit this over the next 3 years in the UK. But just before I finish, I want to go back to the idea of immune suppression. As we've heard, we think it's important, but it is difficult for us to measure We could use HLA-DR, but again, most of us don't have that available in our hospitals to use. But this gene expression profiling, I think, does show potential benefit. There are devices being developed, and we've just completed the recruitment to what we call the IMPACT study, a collaboration with France and Sweden, working with industry partners, bioMérieux, where we've used the film array device, and bioMérieux have been developing with their colleagues in Lyon this immune profile panel looking at gene transcripts to identify high-risk and low-risk patients based around the immune suppression profile. And is it this high-risk group of patients that we can identify? But this is using a point-of-care diagnostic. The film array, many of your micro labs will have it. This got obviously affected by COVID. We were hoping to recruit 800 patients, but because the devices weren't available, we only have about 370 patients. That's completed recruitment now, and we're undertaking the analysis. But just wanted to show you that these devices can be in your ICU. This is my ICU, the little machine, the other side of the sharp spin by our blood gas analyzer. And you can see the hands of one of our research nurses, an ICU nurse, no special lab training, preparing the device, and you get a result within the hour. So this is available to us. So I would summarize by saying, I think we accept now immune suppression is an important part of the dysregulated host response to infection. It is certainly associated with increased rates of hospital-acquired infections and mortality. I would say it's been very difficult for us to monitor it up until now, but these new tests are being developed and they're there, and I think we should start using them to understand our patients and hopefully identify patients for treatment and give you some ideas of what immune stimulation therapies might be possible. Thank you very much.
Let's see if there are questions from the audience. Please.
Thanks, Tony, for that. Really appreciate it. Just a question from the clinical practice. We noticed that the people coming from different backgrounds would have different patterns of their disease. Had there been any studies or any observations that seeing that people coming from different ethnic backgrounds would have different gene expression from the immune stimulation point of view?
That's a good question. I'll have to express my ignorance and say I don't know. I mean, the numbers of patients we've looked with gene expression profiles have been in the hundreds, and therefore to try and then when you break those into different groups and then break them down by ethnicity, it gets into small groups. So I have to say I'm personally not aware of that. I will go back and ask my colleague Kenny Bailey in Edinburgh, who's likely to know that, certainly in his work in COVID. I think that has been a big part of some of the work he's been doing. He may know more. Thank you.
Any other questions? I might just have one because I'm one of those people that...
I suddenly realised, Ronaldo, when I said that
I know you're in trouble because
we
can count so well that we know that a calendar day lasts 24 hours, and if you randomize somebody 4 o'clock in the afternoon, 2 calendar days mean until 4 o'clock 2 days now, and so it makes it complicated. So it's much easier to say until the day after tomorrow. But nonetheless, let me just get back to GCSF. Do you have any data of what it does to the lymphocyte count in people with sepsis?
I don't personally. And I will, again, I'm going to have to ask a lot of my friends. So John Simpson in Newcastle is the guy who's been leading that. I will have to ask. I don't know around on the lymphocyte count. I would suspect it's not huge, but I will ask him if he has that data available.
Any other questions? Okay, thank you very much. That's great.
So back to Germany, more east in Rostock, and my great pleasure to introduce Steffen Mitzner. He will talk about a very innovative therapy with extracorporeal immune cell therapy. Steffen, the floor is yours.
Thank you so much, ladies and gentlemen. Well, this is about an extracorporeal therapy we like to test, and we do actually test in septic shock patients. I'm a nephrologist, and my disclosures are that we cooperate with the German Fraunhofer Society for Applied Science, and we started a small technology company to finance all this work. I brought you this photo. That's the World Press Photo 2007. Taken from Tim Hetherington. He's a British photographer. Took it 2007. He was killed 2011, 4 years later, in a bomb shelling in Misrata, Libya, by Gaddafi forces. And the photo, I think, is quite telling on how we understand cellular immunoparalysis a bit, at least. You know, you're still there. You're accountable. But you're definitely dysfunctional in a very, very complicated situation, not in sick leave, bed at home in your bed. And as many others did, we had tested our lab leukocytes, phagocytes, actually, how they would do if we bathed them in healthy plasma, or then the different stages of clinical severity up to septic shock, and how they would do performance-wise with regard, in this case, of phagocytosis capacity, and this clearly goes down. And others have done this much more elegantly to look at this disability of immune cells, and I'm sure you might have seen this work. If you do autopsies in sepsis patients and you look at spleens of these patients, compare that to patients that died from other reasons, the septic patients basically lost their tools to communicate in the immune communication path properly, you know, and you see that HLA-DR is missing, CD8 in the septic, CD4, and this well then leads to the inability of these cells, all from autopsy material. In the black cases, the septic patients, and the controls that died from other reasons in the blue, to respond to either lipopolysaccharides or other stimuli and produce cytokines like TNF-alpha, interferon gamma, and others. And this is not only true for the, stationary cells in the spleen, but for circulating whole blood. It's basically the same picture you see from septic patients' blood taken. And if we compare this to healthy controls, and septic shock cells always do response-wide, not as good as the controls, and this is in the basal state, as well as if they are stimulated with bacteria or other stimuli. Well, looking at that, we developed an interest in this question, how to help, to overcome this immune cell dysfunction in severe sepsis. And we read with interest all the literature on immune stimulation, including the factors that were given, or whole cell transfusions, so granulocyte transfusions that were done for sepsis as well. And we learned that, yes, there's some good if you transfuse granulocytes, but they are doing harm to their patients as well. They attack the endothelial layer, and that gives damage to the brain, to the liver, to the kidney, probably to all organs. So we came out with an idea to maybe just use the cells, use healthy immune cells, granulocytes, but don't let them into the patient. How's that going? So we started to develop a lab interest in cell cultures. This is HL60 cells, and we trained them to phagocytose, in this case, marked bacteria. We put together a rather simple system where you have a septic patient on the left side, an extracorporeal blood circuit. On the right side, you have healthy immune cells, that's granulocyte concentrates that every blood bank basically can produce for you. And we separated them by a plasma separator, again, a technology that we have at hand. So we would not allow patient cells to leave the system, beyond the blood circuit, and we would not allow the immune cells from healthy donors to enter into the patient. but the plasma could freely move from left to right and from right to left, so they could talk to each other if you want so. And we tested that system in animals, in this case in septic pig, and followed these pigs over a week, and there was a survival difference in favor of the full treatment system, you know, the green ones. And you see the untreated in red, they all died. And the empty bioreactor, the sham approach, if you want, so did not as good as the full one. And this survival difference made impression on our ethics committee, so we were allowed to move on. And that we did, actually. We treated patients. System rather complicated, as you can see on the left side. And what we did so far is we have treated 20 patients with this system. It's non-controlled. We did 2 treatments over 6 hours. We have no idea whether 6 hours is a good time, actually. The pigs we had treated for 4 hours, and that went well. The cells were all alive in the bioreactor, so we said we take it a little longer. So there were 2 treatments, and we just wanted to see what happens and whether this is safe in humans. And this is probably, you cannot see it, but you can read it. It's in Critical Care, published. It's a small group of patients, and what we have is all different underlying diseases and reasons and ages, and on average 60-year-old patients, men and women with all different comorbidities, and Apache 2 on average of 30. SOFA score was around 12. SEPS 2 was 60-something, 60. And we look at what happened. We had for us, elaborated list of cytokines and mediators followed, and we have done that in different positions, actually. We did this before we started the treatment, and then after these 6 hours. So this is in the patient. And then we did it before in plasma samples that went to the bioreactor, so leaving the patient, and then back from the bioreactor in order to see what the cell compartment is adding to the changes. Everything that's highlighted in yellow or green is significant changes. We did not see any decreases. We only saw increases. So we learned that the bioreactor is not eating any cytokines, really. And the green ones are those that are positive significant on both sides. As they were always low and leaving in higher concentration in the bioreactor, we learned that this signal came from the treatment side into the patient. You know, if this increases the green ones, this was, an infusion of cytokines, if you want so. And interestingly, looking at the mixture, we had to learn some of these names, what they really do. It's and we thought maybe this is more immune stimulatory stuff. It's a mixture, you know, you have IL-8, IL-10, and there's eotaxin and rantus that help cells to find their target in the tissues, you know, to leave the vascular system. So an interesting mixture of cytokines. And then this hope that this somehow would make impression on the patient side, on the cell level. At least we can report that we have an increase of HLA-DR. The first treatment was on day 1, and then the first measurement was on day 2 after. And what you see here, this little dip, is from average lower than 10,000 molecules per cell to on average higher than 10,000. And we are quite happy to see that, and our interpretation is that there are more circulating monocytes with a higher number of HLA-DR molecules. Well, and then this is all measurements in the patient. Again, I guide you through, if this is too small, some significances. What we found interesting is that leukocytes significantly went up in 6 hours. In these patients, and again, this is not cells coming from from the bioreactor, because there was the membrane in between, right? C-reactive protein went down, procalcitonin went down, and we followed endotoxin. We had a Limulus test done, and there was we don't know what that means, but there's a little decrease in bacterial endotoxins. And then, as far as hemodynamic stability, norepinephrine significantly went down in the whole group. And I'll show you a single case that was very impressive. See the 2 treatments, 6-hour treatments, and there was during the treatment we could cut the noradrenaline infusion, and that was basically a stable effect. And this is the whole group, norepinephrine going down. And then another thing we did is we had our cells in the lab, and we again bathed them in plasma and in control, and we then measured not phagocytosis, but this time oxybursts, so their capability to do oxygen radicals. And you see the dark gray, they got a healthy plasma, and there was always around 100% performance. If we took the same cells and put the patient plasma on, then again there was this depression in performance, and this disappeared over the treatment time. So if we took a sample after 1, 3, 6 hours, you see how this, got better with time. So clinical data so far, we have 20 treated, 19, to be fair, had septic shock. Immune stimulation, maybe yes. Maybe the mechanism is this import of multiple cytokines from the donor cells. There's modification of the immune cell status, at least for HLA-DR presence. There's some impact on inflammation markers like PCT and CRP. We have some reduction in endotoxins, or no idea whether this is important. Shock situation is the most, visible clinical effect, less norepinephrine need. And obviously very important, the treatments went technically uneventful, and the limitations where it's work in progress, and we have no idea whether this really adds to the treatment. No control group. So, next. We then went on and Gerd Klinkmans in the room. Gerd, hi, thank you for doing all this work. We saw that this technology is, before we could start larger trials, it's really, it's hard to do, it's a lot of logistics, etc. One is this cell component. If you order a granulocyte concentrate in the blood bank, at least in Germany, what you get is a bag of red cells with an increased number of granulocytes on the left side. So we had a cleansing mechanism. We wash and filtrate the cells, and we end up with this on the right side. This is really a granulocyte concentrate for the first time, at least in our hands, And we talked to ethics and the German authorities whether we could use this, and they said, yes, this still seems like a blood product. You could use that as you do on the left side. Okay, that was good. So that's easier. And what Gerd then did, and colleagues, is circulate this in the lab. And what he did was circulate the full, so the red blood cell mixture, and over 6 hours there was no change in cell numbers. Actually, we found all the cells back in the lab, while the concentrate, the numbers went down. So we said, okay, are they dying or what? No, they were doing fine performance-wise. They settled down in the system. So, and that made way for a technically easier system, just for us, this is important. This is how we start with 2 circuits, and we let the cells run here extracorporeally. Now they sit in a plasma filter, and then there's a safety filter, makes the system much more easy. And with that system, and these, technically, we have an easier type of to handle machine. We started my last slides, the reactive ice trial. Just test the system the same as you saw before, but with a control group, multi-center, with 142 patients. Hope to get out 120 for analysis in 2 groups. They are all septic shock unresponsive to standard medical treatment. Again, no, not again, but 6 treatments within 10 days are allowed. Observation period 28 days. We'll follow them up for 3 years to see whether there's something like late immune dysfunction, infections, etc. Primary outcome is clinical safety. Secondary is mechanism of action. So the immune function recovery, both on the cellular level we would like to study, as well on the humoral level, count secondary infections, etc., etc., etc. Interim analysis after 50 patients is planned. We started last summer. We expect to collect patients, include patients over 2 years. We have 9 in the study now. And we use this modified technical setup. And well, with this, it's my summary saying that sepsis is still a bad problem. Cellular immunoparalysis is correlated with the outcome, and the granulocyte infusions that were pretty easy to do are effective but have these side effects I mentioned. And extracorporeal plasma treatment with granulocytes until now appears safe and maybe efficient, and we would like to study this in the future. And with this, thank you very much for listening.
Thanks a lot, Stefan. I think we have time for 1 or 2 questions. Yes, Tobias?
Yeah, thank you for this very nice presentation and a very new direction to overcome some of the pitfalls of sepsis. What I did not understood is you showed the granulocytes are increasing even you do it extracorporeally. So what we learned in leukopenia patients is if granulocytes come up, they are homed to the lung, and then lung damage is much more intensive than it had been before. So we are now very careful in increasing leukocyte numbers. How is it by using your technology?
Clinically, we have no sign of lung dysfunction in connection with the treatment. So, and we have not measured that. Thank you for the hint. I can just report this actually. The numbers go up, and we'll study that in more detail in the future. We have not the impression that this is doing harm to these patients. But thank you. We'll follow it.
We have another question here.
Thank you. This was really inspiring. Thank you very much. I might have missed this, but do you plan, or are you including only patients who have some proof of immunoparalysis? Or, because I didn't see it here, but the way I understood it, it would be a booster kind of thing for my immune system.
Yeah, we thought about that actually, and then we brought together all the brightest brains in immunoparalysis analysis. European group of immunosuppression is helping us in understanding this. And what people find is that actually, if they are clinically that sick, that you are in septic shock and that's refractory, whatever that is, well, we have a definition over 6 hours, and you then follow the immune status, they are all immune suppressed.
Any other question?
I just ask
Rinaldo?
a quick one. Anticoagulation of the system. What do you use for this system?
We'd love to take citrate, but that doesn't work for the cells because they would then stop to phagocytose. They need the calcium, so we need heparin right now, or the others, So that's a drawback, but well, we'll handle it.
Thank you.
Okay, thanks a lot. We are on time. Thanks, Stefan. Next speaker.
And now we're moving to checkpoint inhibitors. Thank you very much. And we look forward to the presentation by David Grimaldi.
Mr. Chairman, dear colleagues, first of all, I welcome you in Brussels. I hope you will have a great Congress, and it's my pleasure to continue this session discussing with you the potential interest of checkpoint inhibitors for sepsis-induced immune suppression. So here are my conflict of interest. I give fees to a little biotech in France who develop immunotherapy. So previous speakers have already explained you that the normal immune system reacts in case of severe infection with a pro and an anti-inflammatory response, and that this results in a few days in a net immune suppression status, even if it's a little bit more complicated than that. If we want to get into the detail of one of the mechanisms of this immune suppression, we have to look at the immunological synapse. This synapse is made by a tight interaction between an antigen-presenting cells and the T helper lymphocytes, the APC presenting the specific peptide to the T cells. But this first signal is not sufficient to activate the T cells, and peculiar membrane proteins are interacting between each other to deliver a second signal to the T cells. And this second signal is crucial in the orientation of the immune response because it can be activator, stimulator, or it can be inhibitor. And in this later case, we are speaking about co-inhibitory molecules. This is one of the main mechanisms the immune system can activate in case of danger, but also tolerate in case of self-antigens or non-dangerous antigen. And the most famous couple of co-inhibitory molecules are the program death 1 molecule and the program death ligand 1 molecule, so PD1, PDL1, and I will focus my talk on these molecules. You have already seen this study from the group of Richard Hotchkiss, these autopsy studies of patients that died from sepsis. I show you here the expression of PD1 on the T helper cells in the spleen that is increased in the patient that died from sepsis in black compared to patients died from trauma in blue. And the PDL1 is increased in the same manner in the APC from the spleen compared to control. You can see also in this beautiful study that co-stimulatory molecules, CD28, CD86, are decreased. In living patients in the blood, the group of Lyon from Guillaume Monnet have published several years ago that circulating lymphocytes and monocytes had an increase in their expression of PD1 and PDL1, but as you can see with the red arrows, there is a great heterogeneity and not all the patients have such increase compared to healthy volunteers. And of importance in this study, the level of expression of PD1 and PDL1 was associated with the risk of ICU-acquired infection. So at the end, if you want, the immunological synapse after a septic insult looks like the left panel of the slides. The co-inhibitory molecules in pink have an increase of their expression, and the co-stimulatory molecules in blue are decreased. So the immune response is driven through energy regulatory response that is associated with nosocomial infection, viral reactivation, and so on. So with this data, a lot of scientists wanted to test the inhibition of this overexpression of PD1, and in animal models, they administered monoclonal antibodies that target PD1 or PDL1. This is one example of these studies conducted in the Hotchkiss group in a double hit mice model. So the mice underwent polymicrobial peritonitis at D0, and 3 days after, they are challenged with candidemia that induce a huge mortality in animals. And you can see on the survival curve that the administration of monoclonal antibodies targeting PD1 or PDL1 were able to increase the survival of these animals. The same group tested the same antibodies ex vivo in T cells from septic patients, and they demonstrate that they were able to restore some of the normal function of the T cells. So there are also, of course, other groups that tested this hypothesis, and all the preclinical data have been meta-analyzed in this paper published in Isicem Experimental. And it's rare in basic science to have meta-analysis, and I think it's very useful. You can see here that globally, to target these co-inhibitory molecules seem favorable in animal models. And if you look only on PD-1 or PD-L1 targets, all the studies that have tested this approach were positive. So the next step was to test it in human, and given the extraordinary success in the oncology field of these molecules, we have a lot of data regarding safety, and the molecule are already authorized for human diseases. So 2 phase 1b have been published so far. The first one in critical care medicine by Richard Skiss was a dose escalating study with very few groups of patients, 4 patients per group with 6 doses. And you can see here that comparing to placebo, the HLA-DR expression of the patients, which is the best marker of immune suppression, increase with a higher dose of treatment. They include patients with 1 organ failure due to sepsis and an absolute lymphocyte count below 1.1 giga per liter. They observed some adverse events, some of them consistent with autoimmune activation, that are the adverse events specific to these drugs, namely diarrhea and lung infiltration. And we know from the oncologic field that anti-PD-1 or anti-PD-L1 treatment can cause colitis or pneumonitis. But in this study, no specific treatment were needed, and there is no proof that it was drug-related. The second study was phase 1 testing an anti-PD-1, nivolumab, in septic patients, same types of inclusion criteria, but no placebo here, more patients. And what you can see in this complex graph, it's basically that the HLA-DR expression increase in the treated patients, but there is no placebo group. So the main goal was to find the right dose and to collect adverse events. Here again, some adverse events were drug-related with 2 rash, 1 thyroiditis, and 1 hepatitis. So these are already known adverse events from this drug, but it illustrates you that this is not so obvious to immunostimulate our patients in the ICU. So with this study, we had some concern with one of my colleagues, Dr. Snaken, because we had the feeling that the strategy was to test these drugs in subgroup of patients, but not in a real individualized way, because absolute lymphocyte count is not the target of the drugs. The target of the drugs is PD-1 or PD-L1. So we conduct this study, this observational study, to see if we can correlate and find an easy marker to predict the expression of PD-1 or PD-L1 expression. And we took advantage of this study to also study the expression of these proteins in case of sterile insult in patients without sepsis. So we included 47 ICU patients. Enrollment was complicated because of COVID, because we didn't want to analyze COVID patients. All of them had hemodynamic or respiratory failure. And we measured HLA-DR, PD-1, PD-L1, as well as lymphocyte count, and compared them to healthy volunteers. So first results is that we observed that septic patients had an increase in PD-1 and PD-L1 expression at the surface of their lymphocytes and monocytes. But this elevation, this increase, was also observed in patients with a sterile condition, and was higher than the control we enrolled. The second result is that we did not find at all any correlation plotting the lymphocyte counts in the x-axis and the PD-1 expression in the y-axis. You can see that this is the PD-1 level is not predictable with absolute lymphocyte count, and that some patients with lymphopenia has high PD-1 expression, but other have a normal PD-1 expression. This is the same story with HLA-DR expression, and we observe the same results with PD-L1. And I think these results leads to individualized through immunomonitoring the results. Otherwise, we risk to have very large-scale studies with a large selection of patients with heterogeneity, meaning that we will include patients with normal PD-1 expression, which are very unlikely to respond to the therapy, given a low signal-to-noise ratio and maybe leading to negative results. And so we believe that our results lead to a more precise immunophenotyping and monitoring to achieve our goal from these last years, to give the right drug to the right patients at the right moment. And to illustrate this strategy, we can talk about this case report we have several years before. This was a previously healthy woman which was severely blunted. After 2 weeks in the ICU, she developed digestive symptoms that revealed an abdominal mucormycosis. And despite antifungal treatment, she required surgery with total splenectomy and gastrectomy due to gastric perforation. And the pathologist found that the peritoneum was positive as well as the vascular margin, and our surgeon told us that they could not resect more tissues, that they have performed a maximal resection of the infected tissues. So we performed an immunophenotyping in these young patients without previous infection, without familial history. And to get short, you can observe here that she had a very high expression of PD-1 in the CD4 positive cells, as well as a low HLA-DR at the monocyte surface, consistent with an immunosuppression status. We decided after a family meeting to treat her off-label with nivolumab, so the anti-PD-1 drug, and interferon gamma. And you can see here that after the treatment, HLA-DR expression increase, PD-1 expression decrease, and the patients slowly heal and could leave our ICU after 3 months of care and leave finally the hospital. She's still alive and gets regularly in our unit. And this strategy have inspired other teams. And I show you here 3 other case reports. Importantly, one of these case reports led to the death of the patient. This was a patient with both an aspergillosis and a cerebral mucormycosis, so difficult to treat. And he died from the cerebral infection despite some response at the systemic level. The 2 other cases was a mucor infection after trauma, treated in the Lyon hospital, and a fusariosis after acute myeloid leukemia, treated with nivolumab with success. And please note that all this group have performed PD-1 phenotyping before beginning the treatment. So in conclusion, I will say that sepsis and sterile severe aggression induce the increase of co-inhibitory molecules, PD-1, PD-L1, but there is heterogeneity here, and not all the patients has this increase. So it would be interesting to know which patients have such increase, but HLA-DR measurement or absolute lymphocyte count seems not to be correlated with this level. We already have treatment to target these co-inhibitory molecules. These are the checkpoint inhibitors that our colleagues from oncology have developed. However, we need tightly designed randomized controlled trials to demonstrate that they have a potential gain. And I think that in some selected case, with a precise phenotyping, these drugs may be useful in case of intractable infections as rescue therapy. I thank you for your attention.
Thank you. Do we have any questions from the audience? Just stop there. Thank you.
Soufiane from France. I have just a question regarding the PD-1 enriched CD4 expressing cells. Did you check any which subgroup of CD4 expressing more this receptor?
No, not in our study, but other groups have done it, but it in circulating lymphocytes. So not all the types of lymphocytes are there. But I don't remember precisely the results. But you have Th1 that increase the PD-1 expression as well as Th2. So it's quite diffuse.
Thank you, Bruno. You would like to?
Yes, thanks a lot, David. Very nice talk. Usually people publish only what succeed. So probably a lot of patients should have received nivolumab and other immunostimulation without publications. If you had to design a trial, would you go for nivolumab alone, or do you think it's necessary to go for nivolumab plus something to stimulate?
It's a good question and tough question. But at this
you
stage,
can make it short if you want.
yeah. No, at this stage, I think nivolumab alone would be very interesting to test. But I would concentrate on the selection of the patients, and I think absolute lymphocyte count is too vague as a criteria. So I would make my efforts on the typing to include patients with an elevated PD-1 expression. It's roughly 60% of the patients, so it's not a too selective criteria.
Thank you very much. Just one more question, otherwise we'll run behind. I think Tony came first, sorry about that.
How easy is it to do that? How do you, the PD-1, can I phone up my lab and ask the clinical lab to do that?
Yeah, thank you. This is an excellent question. So the measurement is not homogenized. So you need to have controls in your lab because you will use antibodies for the flow cytometry that are not the same as mine, not the same unit. So the normal value is proper to each site. And this is a difficulty for a phase 3 study, but I mean, this has been done for HLA-DR. So if we make efforts to normalize the expression of PD-1, there is no reason we could not achieve this.
Thank you very much. Tobias, you can chat to David on the side. How about that? Thanks very much. Go for it. Thank you.
So it's my great pleasure to introduce the next speaker, my good friend Sébastien Gibot from Nancy. He has worked extensively on TREM1 and TREM1 inhibition. Sébastien.
Thank you very much. It's my pleasure to have the opportunity to discuss on the TREM1 modulation during septic shock, but I have one important conflict of interest to declare, because I am one of the co-founders of InnoTrem, the company that developed modulators of TREM1, but I promise I will try to be honest. So, what is TREM1? TREM1 stands for triggering receptor expressed on myeloid cells 1. It's an immune receptor, mostly expressed on the surface of professional immune cells, monocytes, macrophages, and neutrophils, but also expressed by non-professional immune cells, such as endothelial cells. And the role of TREM1 is to amplify the inflammatory response mediated by a Toll-like receptor or a node-like receptor engagement. Therefore, TREM1 does not trigger the inflammatory response. It's just a speed regulator of the inflammation. How does it work? At a resting state, TREM1 is non-active, but once a Toll-like senses the presence of a bacteria or a virus or a fungus, there is an upregulation of the TREM1 expression at the surface and its dimerization. TREM1 therefore associates with an adapter protein called DAP12, and once the still unknown endogenous ligand of TREM1 binds to this receptor, this triggers the intracellular signaling, leading to an over-amplification of the inflammatory response. Importantly, we have shown that a soluble form of TREM1 could be released in biological fluids and easily measured, especially in plasma. And importantly, the soluble form of TREM1, the S-TREM1, is a specific biomarker of the TREM1 pathway activity. And finally, several years ago, we designed a small inhibitory peptide. We called it nangibotide, which was able to act as a decoy receptor for this famous endogenous TREM1 ligand, therefore blocking the interaction between the ligand and its receptor. We and others tested the nangibotide administration in many different preclinical models of sepsis, in mice, in rats, in pigs or monkeys, using endotoxemia, peritonitis or pneumonia. And what was observed was nangibotide was associated with a reduction of the inflammation, a decrease of vascular leakage, coagulation activation, and finally it reduces the organ failure and it improves survival. We next moved to humans and administered in the phase 2A randomized control trial 3 different doses of nangibotide over placebo in septic shock patients. And what we observed was first that the peptide was pretty safe, but also that there was a trend towards a decrease of the SOFA score assessed at day 5, conferred by the nangibotide administration, and especially in those patients with an elevation of their baseline soluble TREM1 plasma concentration. We next moved to a phase 2B trial, the ASTONISH study, with the aim to evaluate the efficacy, the safety, but also to find an optimal biomarker enrichment strategy for nangibotide. We included septic shock patients and randomized them to receive 2 different doses of nangibotide, the so-called low dose of nangibotide, 0.3 milligram per kilogram per hour, or a high dose, 1 milligram per kilogram per hour, versus placebo. Our primary endpoint was the change of SOFA score assessed at day 5 and as compared to baseline. Importantly, we a priori define a subgroup of patients with an elevated cerebral TREM1 plasma concentration, but we had to choose an arbitrary cutoff, and this cutoff of 400 picogram per ml was based on some observational studies and also derived from the results of our phase 2A study. But as this preliminary cutoff may not be optimal, we also plan to investigate several different other cerebral TREM1 cutoffs. ASTONISH was a multi-center study involving 42 different hospitals in 7 different countries. All inclusion had to be approved by a coordinating call center. Patients had to be in septic shock, as defined by the Sepsis 3, for less than 24 hours. And we only included patients with a lung, an abdominal, or a urinary tract infection, and only oldest patient for this latest infection site. There were some exclusion criteria, including severe life-limiting comorbidities, profound immune suppression, and COVID-19 patients. Because COVID-19 patients were enrolled in another study, the Essential study, which will be presented tomorrow by Bruno François, I guess. we hypothesized that non-gibotide should be able to reduce by 2 points the SOFA score assessed at day 5, and we plan to recruit 225 patients with elevated cerebral TREM1. Finally, the study was terminated after 253 patients recruited in the so-called biomarker-positive subgroup. This is the flowchart of the study. Among the 361 patients randomized, 6 were not treated and were therefore excluded from the modified intent to treat analysis that I present you now. Regarding the baseline characteristics of the patients, this was a traditional septic shock patient population, but with a slight imbalance in terms of severity, with slight increased SOFA and hepatitis scores for the non-gibotide high dose group, and also with a slightly more elevated concentration of cerebral TREM1 and IL-6 in this non-gibotide high group patients. When looking just at the patients with high cerebral TREM1, we observe the same trend toward higher severity in the non-gibotide high group, with a little bit more patients under mechanical invasive ventilation and or receiving renal replacement therapy. Other parameters were pretty well balanced. The pharmacokinetics results of the peptide were as expected, that is linear and dose proportional. We had no safety issue, whatever the dose evaluated. We analyzed the primary outcome in the whole population on the right of the slide, and in the population of patients with high cerebral TREM1 at baseline. What we observed was first that the low dose of non-gibotide seemed to add no apparent effect. By contrast, there was a trend towards a decrease of SOFA score at day 5 as compared to placebo in the non-gibotide high dose, but this decrease did not reach significance. And the reduction of SOFA score was more marked in the patients with high cerebral TREM1. We next try to determine an optimal cerebral TREM1 cutoff in predicting the efficacy of non-gibotide. And what we observed was a clear inflection point between 500 and 550 picogram per ml. And after this inflection point, non-gibotide high dose conferred a significant reduction in terms of SOFA score. These SOFA changes were consistent among various subscores: respiratory, cardiovascular, renal, and coagulation. And interestingly, we still observed in every subscore the same inflection point between 500 and 515. The 28-day mortality rates were similar between groups, with 25% death rate. But again, the same inflection point was observed when increasing the cerebral TREM1 baseline cutoff value. And for example, at this value of 592 picogram per ml, which represented the median value of the STREM1 concentration in the whole population, there was a non-significant decrease of 5.6% in death rate. This was obviously not significant because the study was not powered to detect such a change. This is another way to present the results. In terms of a 28-day rate, death and or organ support at day 28, you can see that there was an exponential increase in death and organ support when increasing the cerebral TREM1 concentration at baseline. that is at inclusion. And this exponential increase was dampened by the use of the non-gibotide high dose. Obviously, this is exploratory results. To summarize the main findings of the non-gibotide high dose over placebo in septic shock patients, we can see that there was a decrease of the SOFA score at day 5 as compared to placebo when increasing the soluble TREM1 cutoff. And this change in SOFA score was associated with a non-significant reduction of day 28 and day 90 mortality, and also in a reduction of day 28 organ support. The Astonishing study has several strengths. We used the sepsis redefinition, of course. We tried to limit at a maximum the heterogeneity of the patients in including only those with lung, abdomen, and urinary tract infectious sites. All inclusions had to be approved by a coordinating call center. Several weaknesses, including the possibly inappropriate a priori defined soluble TREM1 cutoff value, and unfortunately there was also a slight imbalance towards less severity in the placebo group. When no safety issues, we were able to identify the optimal dose of non-gibotide. And we think that these results support our precision medicine approach with baseline soluble TREM1 acting both as a prognostic and a predictive biomarker. Our primary endpoint, that is the reduction of the SOFA score, was met after the soluble TREM1 cutoff inflection point. And these SOFA changes were associated with a non-significant reduction in terms of mortality or morbidity. And we believe that these results allow us for the design and the conduct of a larger phase 3 efficacy study. I'd like to thank, of course, all the patients and their families that trusted this new molecule, as well as all investigators and, of course, Inotrem that supported this study. Thank you very much.
Thanks a lot, Sébastien. Any question from the audience? I'm happy to start, maybe. Any effect of steroids on non-gibotide, or have you analyzed the effect of in the two population?
No, I haven't the data. Almost as high as 70% of patients received low-dose steroids, but I don't know whether or not there was still an effect of non-gibotide in this population.
Any other question? Maybe one last one. Would you go for delta SOFA in the next, or mortality?
If we are talking about efficacy study and large efficacy study, we have to move to organ support and maybe a composite score including organ support and mortality at day 28 or even at day 90, I think.
Thanks a lot.
Thank you.
The next speaker is my friend Peter Pickers, come in to tell us about alkaline phosphatase to protect the kidney.
Thank you very much, Mr. Chairman. This is the first time the data of this trial is shared with the public, so I'm happy to do so on behalf of the steering committee and the company, AIM Pharma, that sponsored the trial. As a conflict of interest, as a principal investigator, I received also reimbursement from AIM Pharma. So we all know alkaline phosphatase as a measure of liver dysfunction. And it does so, it is a detoxifying enzyme by removing phosphate groups of compounds. And I will talk about the phase 3 trial that is called Revival, but first give you some background. So for example, endotoxin, lipopolysaccharide, has 2 phosphate groups. And then the whole cascade is initiated when it binds to the toll-like receptor, and you might have septic shock and organ dysfunction and die. If alkaline phosphatase is present with the endotoxin, it can remove one of these phosphate groups, and then the endotoxin can still bind to its receptor, but it will not initiate this inflammatory cascade. And so the idea is it's anti-inflammatory. Even more so, the endotoxin with one phosphate group is bound to the receptor and then acts as an antagonist. So this works for PAMs like endotoxin, but also for DAMs. For example, ATP is a pro-inflammatory compound when it's outside of the cells, and the alkaline phosphatase can remove again the phosphate group from ATP, leading to ADP, AMP, and adenosine, and adenosine is anti-inflammatory and tissue protective. So that's the mechanism of action we think. There's a huge amount of animal studies that show that indeed, if you treat the animals in sepsis models with these alkaline phosphatase, you can actually improve renal function and improve survival. But I will focus on the clinical patient trials, and we did a couple of phase 2 trials, and then I will tell you the new phase 3 trial. So in the beginning, it started with bovine alkaline phosphatase, and this was a small phase 2 trial in only 36 patients. And what we found was that the urinary excretion of a tubular injury marker was less pronounced in the patients that received the alkaline phosphatase, and this was associated with a less pronounced increase or even improvement of creatinine levels. So the endogenous creatinine clearance improved, and we found also, these were sepsis all-comers, that those patients that did not come with AKI at admission, they were less likely to develop AKI, and those that had AKI at admission, they needed renal replacement therapy for a shorter period of time. So then the second trial was more focused on patients with sepsis and AKI. And again, 36 patients, and we had a composite endpoint of creatinine clearance, so the endogenous creatinine clearance, as well as the incidence of renal replacement requirement and the duration of this renal replacement therapy. And this trial was positive again. We found a more pronounced improvement of creatinine clearance in the patients that were treated with the bovine alkaline phosphatase and trends of needing less renal replacement therapy. So based on that, it was decided to develop a human recombinant alkaline phosphatase. And here, a placental and an intestinal alkaline phosphatase was combined. The placental has a very long half-life, and the intestinal alkaline phosphatase has a very high activity. So the combination was a high active, long half-life human recombinant alkaline phosphatase. And this time, a larger phase 2 trial was done in 300 patients with sepsis and early AKI. The primary endpoint that was chosen was the improvement in endogenous creatinine clearance over the first 7 days. And although you can see that there is a trend that is better in the treatment group, this was far from significant, so the primary endpoint was negative. However, we followed up these patients for 28 days, and the total curve over 28 days was significantly better in the patients that were treated with alkaline phosphatase, so a better renal function. More striking, however, was the benefit in survival, and we found that the absolute survival was double in the patients that were treated with alkaline phosphatase, and this was an effect that persisted up to day 90. And as a consequence of this, the major adverse kidney events, the MAKE 19 on day 90, was also significantly better in the patients treated with the recombinant alkaline phosphatase. So that's the background. Now the phase 3 trial I'm about to start to present to you. This was the trial again with the human recombinant alkaline phosphatase. We did this trial in 3 cohorts. The main group with a baseline renal function, a pre-existent renal function that was normal. We had another cohort with patients that had pre-existent chronic kidney disease. And we had a separate cohort for COVID-19 patients that came into the ICU with sepsis and shock as well as AKI related to COVID-19. And we treated those patients with alkaline phosphatase, 1.6 milligrams per kilogram versus placebo in a double-blinded fashion. And we had a sequential adaptive design with 4 planned interim analysis and stopping rules that were predefined for futility or early success. If the trial would run to its completion, 1,400 patients would be included in the main study population. The primary endpoint that was chosen based mainly on the very strong signal in the STOP-AKI trial was mortality. And we discussed with FDA, EMA, etc., the design of this trial. The trial was performed in the United States, Canada, Europe, several countries, but also in Japan, Australia, and New Zealand. So a very worldwide trial. The main inclusion criteria were adult patients that were admitted to the ICU with sepsis, with a vasopressor need, so they needed to have at least an infusion rate of norepinephrine of 0.1 microgram per kilogram per minute, and also AKI based on KDIGO criteria. The usual exclusion criteria, I will not go into that, and there were a couple of differences compared to the previous trial. We only included patients this time that were on a vasopressor, because in the previous trial, that was actually 90% of the patients, and those patients that were not on a vasopressor did not have any mortality. And we also excluded patients that fulfilled the AKI diagnosis, but still had an eGFR at that moment of AKI above 60, because again, these patients had a very low mortality rate in the previous trial. And so also the primary endpoint was changed from a renal focus to a survival focus. And again, it was an adaptive trial design with predefined stopping rules. This is the flow chart. As you can see, we had over 300 patients in each arm, mainly patients in the main population, but about 30 patients per arm in the CKD cohort, and 20 and 13 patients in the COVID-19 cohort. These patients were treated in a blinded fashion. It was also not allowed by the physicians to measure alkaline phosphatase in the bloodstream, because that would lead to deblinding. And so the data is presented for the whole group for efficacy. This is the table 1. You do not have to read it. There were no major disbalances between the groups. So the first planned interim analysis was in the main cohort. This is not the CKD or COVID cohort, the main cohort, after 400 patients. And based on the primary endpoint being mortality, this was also done on mortality. And mortality was not significantly different from each other, but if anything, a little bit, a few percent higher in the treatment group. So this actually triggered the stopping rule, and the trial was stopped for futility. So the efficacy results I will actually present for all the different cohorts, the 3 different cohorts combined. Again, also in those other cohorts combined in total, there was no signal whatsoever for survival. However, the key secondary endpoint was MAKE-90, the major adverse kidney events, and this was significantly better in the treatment group, as you can see here. And if you look at the different components of the MAKE-90, you can see that it was mainly driven by the number of patients that needed renal replacement therapy, which was 28% in the treatment group, while it was 36% in the placebo group. What is of interest also is that the renal effects might be related to the pre-existent renal function of these patients. Patients that are known with chronic kidney disease do have less renal reserve when a sepsis insult may occur. And so what you would expect is what we see in red in the placebo group, that if the pre-existent eGFR, so this is prior to the sepsis and ICU admission, if that is lower, they are more likely to have a MAKE-90 event following sepsis and AKI on top of CKD. But this relationship was completely abolished in the group that was treated with alkaline phosphatase. So this means that the treatment, the therapeutic efficacy, is mainly present in those patients with a more pronounced lower eGFR pre-existent prior to the sepsis and AKI values. And this was a significant interaction. The overall summary of adverse events, again, you do not need to read this, as you can appreciate from the p-values that are mentioned. If anything, there were less adverse events reported in the treatment group compared to placebo, and a similar amount of serious adverse events were reported in both groups. So, my conclusions are, what we've learned, that it's actually pretty difficult to choose the right primary endpoint at the right time. When we had renal function, we found a significant effect on mortality. When we had mortality, we found a significant effect on renal function and not mortality. So we could not show any consistent survival benefit. So we should assume that it's not there. However, if you look at the different trials, there is a very consistent benefit for the kidneys. Every time we see a benefit, if it's endogenous creatinine clearance or the need for renal replacement therapy, etc. And so these renal effects of the recombinant alkaline phosphatase are also of clinical relevance, of course. And so we should look at maybe to design a new trial again and focus on patients first with pre-existent impaired renal function, because these are the patients that seem to benefit most, and look at the renal endpoint as the primary endpoint. But this is something actually that should spark discussion, I think, in the field, because the choosing of the primary endpoint is the human factor, right? It's just, if this trial was actually, the choice would have been that the MAKE 90 was the primary endpoint, it would have been a positive trial, but now it's a negative trial because the primary endpoint was not met. And with that, I want to thank the trial steering committee and also the people of AM Pharma for sponsoring this study, and I thank you very much for your attention.
Thank you, Peter, for the outstanding presentation. We got time for questions. Here's one of them.
Thanks, Peter. Just a quick question. Did you have any data about the long-term consequences, including renal replacement therapy requirements? So any patient that would require long-term dialysis?
No, so there are actually, we use two definitions of the MAKE 90 because this is consistent with literature. So one definition is that you will actually look how many patients are on renal replacement therapy still on day 19, and the other one is actually how many patients are somewhere up to day 19 on renal replacement therapy. What I presented is the last one. So they are on renal replacement therapy for some time during this moment of day 90. All of these patients actually come off renal replacement therapy, so that there's no difference in the moment of day 90. Nevertheless, we do know from observational databases that if you have had renal replacement therapy in the ICU, if you would actually follow up these patients for 5 or 6 years, then the chances that they will become end-stage renal disease patients are 100 times higher. So these nephrons are lost. You can compensate it for a while, but your slope of the decrease of eGFR is definitely more steep. And so there should be long-term effects, but it's very difficult, of course, to show the effects of an intervention on that long term.
Bruno, you have a question? Yeah.
Thanks a lot, Peter, for the presentation. I do imagine that you have dig into all those results. Have you compared the two trials, the phase 2 and the phase 3? Have you identified anything different? Sites, management, standard of care, something?
Right.
Because it's really disappointing at the end of the day.
I think it's a very well recognized phenomenon that if you go from a phase 2 trial to a phase 3 trial and you need much more sites, that the therapeutic efficacy is most of the time like half of what you found before, right? So that's one thing. And also we actually changed the in- and exclusion criteria a bit also to make it feasible in the practice. And one of the changes, for example, was that in the previous trial, patients that came in with already an elevated creatinine level needed to show a further increase as proof of ongoing AKI. Some of these patients would have a decrease of creatinine, and then it was resolving AKI, and they were not randomized. In this trial, we said, well, it takes too much time, too much work, so everybody that comes in with sepsis and AKI at that moment is enrolled. So we used sepsis 2 definition in the previous trial, we used sepsis 3 in this trial. Maybe sepsis 3 needs organ dysfunction to be present, so maybe it was a more established organ dysfunction already. So there are differences between the 2 trials. And what is really interesting, I think, also, is that we are now actually looking into endotypes and to see where the benefit was in stop AKI, and then find out if indeed if we look for the same endotype of patient, if we can find a benefit there, so that that's suggestive of a subgroup of patients that might benefit.
Thank you very much. Any other question? Great. Thanks very much for the presentation, Peter.
I think we have kept the best for the end. After all these mails, we are ending with Julie and Lennie. This is the best for the end of the session. So great pleasure to introduce Julie Helms from Strasbourg, France. She has been extensively working on coagulation, DIC, plasma therapy. So Julie, the floor is yours.
Thank you. Dear colleagues, I first would like to thank the organizing committee for having invited me. And it's a real pleasure to talk to you about targeting coagulation, and I will show you why it is the future in sepsis therapy. Here are my conflicts of interest. To put things in context, I first would like to remind you why disseminated intravascular coagulation, or coagulopathy more in general, is a critical issue for sepsis. The first point is that disseminated intravascular coagulation is a very frequent complication in sepsis. As you all know it, sepsis is due to an inadequate host response to infection, leading in 30 to 40% of the patients to disseminated intravascular coagulation. DIC is due to dysregulated coagulation activation and fibrinolysis and defective fibrinolysis. And as we have something like 49 million sepsis per year in the world, we probably have something like 20 million DIC per year in the world. My second point is that DIC contribute to multiple organ failure. And as you know, patients with symptomatic DIC may develop 2 types of clinical signs, including, for example, bleeding complications, which you can already forget because patients with sepsis-induced DIC do not have bleeding complication, and thrombotic complications, including microthrombosis in fingertips and toes, like you can see here in the photo. But you can also imagine that microthrombosis are also present in the microcirculation from all organs, leading to organ failure. And as DIC will contribute to multiple organ failure, it will also contribute to mortality. In this study, you can see in red patients who do not have a DIC, and in blue, the patients with the same disease who develop a DIC. Patients with DIC have a 40% increase in mortality rate. So now that we know that DIC is a really critical issue in sepsis, we have to make a good and early diagnosis of DIC. And you will see that it is not so simple, because so far it is recommended to use one of the available scores to make the diagnosis of DIC. Here is the ISTH score. It uses global hemostatic parameters like platelets, prothrombin time, fibrinogen, and the dimers. But as you can see, it's really not convenient to use at bedside. So the International Society of Thrombosis and Hemostasis recently recommended to use a simplified score, which is called SIG score. And SIG score only takes into account platelet count, prothrombin time, and SOFA score. And as all patients with sepsis have a SOFA score of more than 2 points, you can keep only platelets and prothrombin time. And if SIG score is positive, then you should apply the ISTH score. Just bear in mind one important thing. If 6 score is positive, we will talk about sepsis-induced coagulopathy. If you have an ISTH positive score, then it is a disseminated intravascular coagulation. But you can see that these scores have several limitations. First, they are not easy to use at bedside. They only allow late diagnosis of the IC, and they don't allow to find the stage of coagulation activation. So we clearly need new biomarkers to make an early and reliable diagnosis of DIC, but unfortunately I will not have time to talk about it in this presentation. So once sepsis-induced coagulopathy or DIC is diagnosed, we have two main options to target it. The first one is to limit excessive coagulation activation. We have disseminated microthrombi, so the first thing we can do is probably to anticoagulate these patients. And you can see that we have already tested several anticoagulants and we have several available targets. The second option is to restore fibrinolysis, because fibrinolysis is meant to allow lysis of thrombi. So if you have disseminated microthrombi, probably that increasing fibrinolysis would be beneficial. We have already tested several anticoagulants during the past decades, and as you can see, none of these anticoagulants have proven any beneficial effects if we look at mortality. You can take TFPA, antithrombin, protein C, activated protein C. None of them decreased mortality, but all of them increased bleeding risk. So far, all the clinical trials have been either inconclusive or negative. And if we try to understand why we only have negative trials, we probably can find that they all have the same flaws. The first one is that all these trials have included very heterogeneous patients. They have included patients with sepsis, regardless they had or not a DIC. The second point is that they have included patients with different DIC stage, which means that we have patients with a thrombotic stage, but also patients with a very late hemorrhagic stage. If we try to find solutions to this, the first one will be to correctly stratify our patients in order to identify patients who are likely to benefit from anticoagulant treatments. The second one is that we have to find the good therapeutic window to give them the treatment. And here is the first large randomized control trials, which has included only patients with sepsis and a coagulopathy, which was defined by a positive 6 score. Scarlet trial compared thrombomodulin versus placebo, and the main outcome was day 30 mortality. Unfortunately, you can see that this trial was also negative. There are no difference in mortality at day 28 between patients treated with thrombomodulin or treated with placebo. However, you can see that in the subgroup of patients who still had a coagulopathy at the time of treatment, there was a significant beneficial effect of thrombomodulin. So in this trial, they probably correctly stratified the patients, but maybe not identified correctly the therapeutic window. We have performed a post-hoc analysis of this trial by investigating only the patients included in France, which was 149 patients out of the 800 patients that were included. And you can see that we had a greater efficacy of thrombomodulin in French cohort, which was due to two main things. The first one is that we included more patients who still had a coagulopathy at the time they received treatment. The second point is that we had fewer patients who were treated with heparin, which will inhibit the effect of thrombomodulin. So it is only a post-hoc analysis, but with several limitations, but maybe it will allow to lay the groundwork for a new trial. Also, you remember that all the anticoagulant treatment increase the hemorrhagic risk in our patients. Maybe we could find one target that would not increase the bleeding risk in these patients. And for that, inhibiting the interesting pathway or contact phase activation would be the solution. If we take, for example, factor 11 is non-essential in physiological hemostasis, but it will play a key role in thrombus growth. So if we inhibit factor 11, we will not have an increased bleeding risk. There have been several strategies that have been developed to inhibit factor 11, as for example antisense oligonucleotides, antibodies or aptamers, and also small molecules. None of this has been evaluated in sepsis for the moment. And as I told you, there is a second option to treat patients with sepsis-induced coagulopathy. It is to restore fibrinolysis. For example, we could target neutrophil elastase to decrease plasminogen degradation, or we could bring deficient proteins by bringing plasma. And as far as plasma therapy is concerned, we have three main randomized control trials which are interesting. The first one is from a German team who has included 31 patients with septic shock, and patients were treated with therapeutic plasma exchange. And as you can see, TP was able to reduce the imbalance between pro and anti-inflammatory factors in these patients. There is a second small randomized control trial, including 112 sepsis-associated DIC patients. Some of them were treated with plasma exchange, and as you can see, plasma exchange was able to improve coagulation function through an improvement of endothelial function. Also, it resulted in better outcome in these patients. And the third small trial is in children. This team has included 80 children with sepsis or septic shock with non-overt DIC. Non-overt DIC means that it is a very early stage of DIC. They have treated them with either fresh frozen plasma with heparin and tranexamic acid or with standard of care. And you can see that patients receiving fresh frozen plasma and the other treatments had a better outcome and did not progress to overt DIC. And there is a last trial which you cannot have heard from because it is not published yet. We have conducted a small pilot trial including 60 septic shock patients with sepsis-induced coagulopathy, and the patients received either placebo or octaplas, which is plasma, at day 1 and at day 2. And we have been able to show that plasma was able to restore fibrinolysis with increased plasmin generation at day 1 and day 2. And also, possibly, we have a trend toward mortality reduction, although it is not significant, of course. So, as a conclusion, I think there are three main messages that I would like to remind. The first one is that we have to find a way to correctly stratify our patients for adequate treatment allocation. The second one is that we have to identify the right time window. And the last one is that we have to find new targets, maybe new antithrombotic agents that would not have an increased bleeding risk, for example. Maybe we could target fibrinolysis pathway, which has never been done so far, or maybe we could try to target both of them, which will be quite logical. Thank you for your attention.
Thanks a lot, Julie. We have time for one or two questions. Is there any question in the audience? Just a question about DIC. I do feel that most of the septic care patient and septic shock patient have a DIC, in fact. And don't you think that we not targeting enough of DIC severity? Shouldn't we go for really severe DIC? I mean, for when designing a clinical trial? Have you any opinion about that?
I think if we take all septic shock patients, we have about 90% of them who will have a 6 score, a positive 6 score. If we take the ISTH score, we will have only 30% of them positive. So DIC is very frequent. Yes, I agree. SIC is even more frequent. So it's quite difficult to target, to design a clinical trial using 6 score, because we will target nearly all the patients, which is not the point. And if we try to design a trial not using 6 score, it will be much more difficult because the other scores are not useful. So I think the best thing would be to use a biomarker, and there are several ones that should be validated quite soon, I hope.
Yes.
The question is quite fundamental. To bring things together, there is many disulfur bridge in coagulation, therefore sensitive to oxidation. What did you mean is the link between oxidative stress and increase of redox and coagulation? The further question was if you can control oxidation, then you can improve or not coagulation.
I think it's quite a difficult question because oxidative stress will be involved in all the mechanism of sepsis and septic shock. So I would think that inhibiting oxidative stress would be quite the same as inhibiting inflammation. It might not be so beneficial if we cut it completely. I'm not sure that inhibiting oxidative stress would lead to no coagulopathy. I think there are so many other mechanisms that are involved except oxidative stress that I'm not sure it's a good target because it's not precise enough. It's not specific enough.
Yeah.
You discussed the trials about plasma exchange and about giving plasma your personal data. Arguably, that's not just a coagulation intervention, it's quite of a blanket intervention that's also immune modulating. Do you think the coagulation effect is specifically important or that it's specifically targetable, or is it just a blanket intervention that makes it work?
No, I think it's not targeted on coagulation specifically. It's a more larger intervention, as you told it.
Yes, maybe one last question.
Thank you. Maybe I can just comment on this because I'm the PI of the plasma exchange trial. So I'm Sasha Davis from Zurich. I think it's not just the coagulation, but I think it is a key point, and this is also what's really different using plasma exchange compared to adsorption technologies. So I think the coagulation really matters in terms of these plasma exchange trials.
Thank you.
Thanks a lot, Julie.
Very good. We have another speaker now, Lennie Derde, who's going to concentrate on personalizing therapies. Thank you very much.
Thanks very much, and thanks everybody for sticking around in these tropical temperatures. This is a very bold statement. I will show you first that I have no conflicts of interest related to this talk. So we will personalize therapies is a very bold statement, but luckily for me, the speakers of the session today have done most of my work for me, because I think in their talks we've discussed lots of things that have kind of indicated that we are trying to personalize therapies, and we will do that going forward. So then why do we have to talk about it? Well, if you want to know why you have to talk about something, you always have to go back a little bit in time. This is a picture of the Atomium. You all know this building. It's a landmark building in Brussels. You can actually see it from the conference center. And it was built in 1958, state of the art at the time. But it wasn't made to last. So it underwent a very major revision in 2004 because the whole outside of the building had to be redone to again become the state of the art. in that same period of time, 10 years before, the first randomized clinical trial, modern day randomized clinical trial, was conducted. And it compared bed rest alone to bed rest plus streptomycin for the treatment of tuberculous pneumonia. And this was the clinical reality at the time. So we didn't know a lot about pneumonia. We didn't know a lot about the causes of pneumonia. And basically, everything you could do in 1948 in a hospital or outside a hospital is you could make policy. So on the left is a health policy minister in this photo. You could pray and you could care, right? You had nurses, nuns, and health ministers, and that was about it, right? There was no more knowledge. There was nothing much we could do. That's a huge difference from the clinical environment we work in today. We work in a highly technological environment in which we know lots of stuff about underlying biological mechanisms of sepsis. We know lots about host responses. We know lots about interactions between the host and the pathogen. We know about PAMPs and DAMPs and toll-like receptors. We know so much more, and we can do so much more. But still, we use the clinical trial design from 1948. So I think we are shifting. And I think the speakers in the session today have also showcased this. And I really like this manuscript. I advise if you do anything tonight in terms of work, then you read this manuscript. What this shows you is kind of the thinking process we've gone through as intensivists over the years. And in the last period of ICU, we focused on syndromes. We talk about ARDS, right? We talk about sepsis. These are all very syndromic approaches. And I think, now is when we are starting to realize that though there may still be a use of improving definitions for these syndromes, we want to move towards more precision medicine. We want to personalize the treatments for our sepsis patients. As somebody said, I can't remember which speaker it was, we want the right treatment for the right patient at the right time. That is personalizing medicine. So what we actually want to do is move from this game of who is who, where we very roughly say, this is a sepsis patient, this is an ARDS patient, to the more in-depth knowledge that we have, because we know lots about these patients. So we have their clinical profile. Let's say these are 10 patients. They all have different clinical profiles. This is what you can see and feel with your hands and ears and your stethoscope. They also all have different physiological parameters, of which we can measure much, much more than in 1948. They all have a different radiology signature, right? We get different information from the radiology that we do. They may also have different immunological profiles, and they may have different proteomics, metabolomics, and other omics signatures. So what we actually want to do is we want to group these patients into clusters that look alike. This is the fact that, people are saying we shouldn't put all the sepsis patients into one trial. We want subgroups, right? We want little clusters, and the ultimate cluster is one patient, right? We want to know what to do for this patient at this time with this disease. And you can take various approaches into identifying these clusters. I'm not going to go into that now. You can use AI, you can use machine learning, you can use endotypes and phenotypes, but the essence of it is we don't want a big group, we want clusters of patients. And if we can then measure something in these patients that identifies them as being part of that group, and that biomarker, because something we measure is a biomarker, I'm going to be very general, if we can then relate that biomarker to a response to treatment, which is, what we've seen in every single presentation here, right? We have a biologically plausible mechanism, we have something that identifies this patient, and then we have a treatment that affects that same thing. That is what we call a treatable trait. And I think this is a really important concept. What you want to investigate new treatments for sepsis is you want to be able to measure something in your patient that predicts a certain response to therapy, and then you have the right treatment for this patient at this time. And it doesn't have to be the same diagnosis. It doesn't have to be the same syndrome. Here I've made up a completely random example of different types of patients, so patients with infection, trauma, pancreatitis, and surgery. And all these patients could have the same underlying biological defective system, for instance, something in a TLR pathway activation that you can measure and that predicts a response to treatment. That is then a treatable trait. And combining that and testing treatments for those patients, that could maybe help in personalizing sepsis therapies. But then we rapidly get into trouble because we know so much and we have so much. So this is one of your subgroups, and you have found 2 potentially effective treatments in phase 1 and 2 studies. If you now want to do a phase 3 study, and you have this subgroup, and you don't just have 2 options, but you may have 2 other options that could also work for these patients, and you may have other dosages or other administration routes. Doing clinical trials, phase 3 clinical trials in this subgroup is going to take you the rest of your career. But now we don't have one subgroup, we have all these subgroups. So this becomes really, really complicated really, really soon. And doing A versus B trials to identify the best treatment for this patient at this time is not going to work. It's very ineffective. It can work, but it's very ineffective. So I propose what Alan Kay has said. You may not know Alan Kay is not a very glamorous photo, but this is a guy who is involved in development of user interface, so he has more influence on your daily life than you think. And what he said is simple things should be simple, and complex things should be possible, and I fully agree to that. So we may have to do more complicated things to be able to test all these personalized therapies, but it should be possible. The one thing we should not change is randomization, because if you do a phase 3 clinical trial, randomization is the hallmark of that, and it allows you to draw causal inference, which is great. Absolutely magical. But what you can do is you can innovate clinical trials. And the first thing you can do is you can innovate the methodology of clinical trials. For instance, you can do a platform trial, can do an adaptive trial, and if you do both at the same time, you can do a full adaptive platform trial. I'm going to spend a little time to explain to you what platform trials are, because platform trials are one of 3 things. The first 2 are the most simple. They are either an umbrella trial or a basket trial, and it's actually the reverse of each other. So in an umbrella trial, what you have is you have a single disease like breast cancer, then you screen for the presence of target biomarkers. You put these different biomarker positive patients into different groups and you investigate targeted therapies. So everything happens under the big umbrella of one trial. A basket trial is the reverse. If you have a common therapeutic target, like a treatment for TLR pathway activation, it doesn't really matter which disease this biomarker is found in, but then you want to test that intervention in all those different diseases with the same target. That's a basket trial. A platform trial is a kind of a perpetual form of that. So what happens in a platform trial is you stratify patients by biomarker. So these are the little clusters, right? And then you start investigating different drugs. And different things can happen to these different subgroups in the course of time. For instance, in the course of time, you could find out that there's a new drug for biomarker A positive patients, and you can start testing a new drug against intervention 1, 2, and control. And then at a certain point, you could find out that intervention 1 is the worst out of all of them and stop recruiting to that drug while continuing all the others until you have found which one is best. For biomarker B positive, you could still be recruiting, or you could stop for futility. And for instance, biomarker negative patients, the last little cluster, they could be, for instance, only 2% of your population, but still be included in this larger platform trial. It just takes you longer to recruit. And the interesting thing is, because we learn all the time, right? There's development of all these new compounds. You could actually enter new biomarkers with new potential therapies into that same platform trial. So it's a much more comprehensive way of doing trials. In an adaptive platform trial, what you do is you don't kind of guesstimate the sample size at the start, which is always a disappointment, right? Sample size samba. But what you do is you draw lines in the sand. You agree with all the trialists what your level of confidence has to be before you are confident that something is good. So that's your green line in the sand. If an intervention does better than that, that's the best, and we stop the trial. In this example, we have 3 interventions and 1 control group, and let's run this adaptive trial. So you can see intervention 2 is doing a little bit better, nothing much happens, except in the little blue figures above the blue box. You can see that there's preferential randomization into the more promising intervention. That's a system called response adaptive randomization. It's something you can use, you don't have to use it, but it can gain you efficiency. Further on in the trial, randomizing more and more patients, you could see that intervention 1 drops below the threshold for futility that you had agreed before you started the trial. At that point, you don't know which one is the best, but you know one is worse than everything else. You can stop randomizing patients to one. You can stop exposing your patients to a futile interventions. That's great. And then a little further on in the trial, you could see that intervention 2 crosses the pre-specified threshold for superiority. At that point, that is the best treatment for that cluster of patients. And we can implement that as standard of care. That's how adaptive trials work. So I just want to say this is not a 42. As you know, 42 is the answer to the ultimate question of life, the universe, and everything. So this is not the ultimate answer to everything, but I do think it can help us evaluate new therapies for sepsis patients more efficiently and more cost effectively. And I think the key thing here is that we consciously decide to not have instant noodles anymore. And you'll go, huh? But instant noodles is like, you don't think about it. It's like one box of sepsis patients, just add water, we do another trial, we run it to the end, and then we're finished. That's like eating instant noodles. That's not smart. That's not collaborative, and it's not a really good diet either. So what I propose we do is we embrace that we want to test multiple therapies for multiple subgroups of patients identified by treatable traits, and we work like a Michelin star restaurant does. So you have people cutting the vegetables, and they have to talk to the people, plating the food, the people bringing the food to the table. So we need basic scientists who know everything about TREM or about recombinant alkaline phosphatase to help set up the trials, right? But we also need people who run these trials to make sure we don't do negative trials for 20 years with all these very promising sepsis therapies. So that is my message to you. And with that, I'd like to thank you for your attention.
Are there any questions from the audience?
Yep. Thank you, Lennie. Very inspiring. The concept is really great, but all is based on the fact that you have a subgroup or subpopulation which is really, really similar. Because because with what you show with biomarkers, how confident you are that you are really identifying a subgroup likely to benefit from what you do. Because this is, and the issue with platform trial is how deep into those type of patients you can go, especially to address the question and the failure. But the concept is great.
Yeah, so let me take this one. So your question is like, how can you be sure you're testing the right subgroup of patients? I think that's a question for every trial. That's not specific for platform trials or adaptive platform trials. But I do think that, we shouldn't work in silos. So I really think that, having people who have in-depth knowledge of a new compound is really, really valuable for choosing the right endpoint, for choosing the right subgroup, for stratifying patients, all of which I think are not easier to do, but maybe more sensible to do within a larger platform trial.
So, can I ask a question?
Yeah.
Very good. Excellent. I'm the boss. I can decide. So, as you know, we've in Australia, the Australian New Zealand Intensive Care Society has gone big into platform adaptive trials, particularly during the COVID period, and is doing lots of stuff like that in community-acquired pneumonia now that COVID is finished, and a lot have been published, and I think it's been quite an undertaking and a significant enterprise. However, there is an ongoing challenge, which is the challenge of selling the results to the paying public, because the groups are relatively small because of the process of grouping, as you suggested, And in order to make decisions relatively quickly and not wait until one is 99 years of age to accumulate enough people, you either have an immense number of centers that participate, or you have to do Monte Carlo chain simulation of what would happen if you had similar patients 100,000 times, and you go really deep into the world of the dark arts of statistics. And when you come around and you tell people, trust us, we've done this fantastic supercomputer 3 days of Markov chain Monte Carlo simulations, and this treatment is futile, don't do it. Oh, okay. Or, trust me, this works. You have to sell it to the public, and there is this black hole in between what you've done and what the result is.
Yeah.
I think that's really difficult.
Yep, I agree.
It's really difficult. Really, really difficult.
Yep, I agree, especially because even methodologists have all been educated with, these trials are often done with Bayesian statistics. I think that's what you're also referring to. And not many people have been trained in that. So it's even though it's older than frequentist statistics, it's relatively new to implement it in this way. And I fully agree that understanding how such a model works and how simulations work, that's something we all have to get used to. I do think it's a process, and I hope that, if we keep explaining, people will understand more. I do think there are also people who read papers who don't understand the logistic regression, so not in this room, obviously.
Of course,
I know
never.
that. And also, as you say, there can be other approaches. So you can also choose to not go into this, but just recruit 50,000 patients. That's also a solution in this, more globalized and connected world. So that's why I'm saying it's not 42. It's not the answer to everything. But I do think in kind of wanting to personalize therapies, it could be one of the things that helps.
I would like to close the session by saying thank you, and I agree with you, and maybe one day will come, not in my lifetime, when clinicians will stop believing in the things they believe in and actually bloody randomize every patient to a trial. Thank you very much.
Thank you.